Hello again everyone, this is Dr. Habib and welcome back to the channel. In today's talk we'll be discussing the pathophysiology of COPD. Before you get started, let's have a look at a few facts with regards to COPD in the UK. There's about 3 million people living in the United Kingdom with COPD, 30,000 deaths per year, a staggering 100,000 or more admissions to NHS hospitals. This makes it the second most common cause of lung disease in the UK, the first one being asthma, and also the second biggest cause of lung disease-related mortality, second to lung cancer. So it's important to remember that chronic obstructive pulmonary disease encompasses two disease entities called chronic bronchitis and emphysema. In this lecture, we'll start off with chronic bronchitis and then move on to emphysema. So chronic bronchitis refers to the symptoms that a patient complains of, and this is a cough productive of sputum for 3 months over 2 consecutive years. Okay, so this is the clinical definition of chronic bronchitis, and let's have a look at this illustration over here. So notice how the airway on the left side is nice and clear. The lumen, denoted in white, is quite patent and open, facilitating good airflow. The red denotes the smooth muscle layer, and the light pink is submucous layer. Having a look at the obstructed airway on the right side, there is constriction of the smooth muscles, which is the outermost layer, swelling of the submucosal and respiratory epithelial layer, and narrowing of the airway lumen, contributing to airflow obstruction. You'll also see that the mucus plug over here is shown in yellow and will also exacerbate the problem. Some of the other pathophysiological processes which happen are mucus gland hypertrophy, metaplasia of the goblet cells in the bronchiolar epithelium, bronchiolitis, and finally secondary infections due to pathogens. And having a look at emphysema, so bear in mind that this is a histological diagnosis and is defined as an abnormal permanent enlargement of air spaces with alveolar wall destruction. Have a look at this histological slide over here. You will see the normal alveolar architecture on the right side. However, on the left side, you will see that there's enlargement of the air spaces separated by thin septa over here. The capillary supplying these are also bloodless, and when this ruptures, it leads to bigger air spaces, which are known as bullae. And in the normal lung, the surface area for gas exchange is abundant, and that is severely compromised due to emphysema, as you can see on the left side over here. Okay. So what are the causes of emphysema? Without doubt, the first one is cigarette smoke and hereditary causes such as alpha-1 antitrypsin deficiency. So how does cigarette smoke cause emphysema? Well, it leads to a cycle of inflammation, which is chronic, and it leads to generation of macrophages and neutrophils. And these cells eventually produce an enzyme known as elastase. And the main purpose of elastase is to catalyze the lung parenchyma, eventually leading to destruction. That also causes loss of surface area for gas exchange and also severely compromises the ability of the lung to perform elastic recoil. Cigarette smoke also contributes to emphysema by inactivating alpha-1 antitrypsin, which is an inhibitor of neutrophil elastase, thereby leaving too much of it to attack the lung parenchyma. It does this by oxidants in tobacco smoke and free radical release from the neutrophils. Along similar lines, alpha-1 antitrypsin deficiency, which is an autosomal codominant condition, you have too little of the normal alpha-1 antitrypsin, thereby leaving the neutrophil elastase to eventually cause emphysema. And unsurprisingly, if these people who have the deficiency smoke, the emphysema onset is a lot quicker. In the diagram below, I'll explain how emphysema will lead to retention of air in the lungs. So on the outside, you have intrathoracic pressure, also known as pleural pressure, and let's say that's -5, and the elastic recoil is in the red arrows, and that's +5, so the net effect is 0, and there's no air moving in or outside the lungs in a resting individual. And having a look at the second scenario here, let's say your lungs are normal, and you're forcefully trying to expire or exhale the air. So the elastic recoil remains constant. Notice how the intrathoracic pressure has now become positive because you're expiring. Remember, 5 + 1 gives you 6. So this is enough intraluminal pressure to force the air out from the airway in this direction. However, if you continue to have forceful expiration, i.e. if the intrathoracic pressure is increased, you will notice how even you with your normal lungs will eventually become wheezy. And in the last scenario, in COPD, you'll see how the elastic recoil is greatly compromised with a value of only +1, and this is due to the process we've discussed above, and the intrathoracic pressure is the same. And you'll see how the intraluminal pressure is still not enough to force the air all the way out from the lungs. So what happens eventually is that this pressure is going to decrease and be overwhelmed by the intrathoracic pressure on the outside here, and your airway is going to collapse. Which is why patients with emphysema have pursed lips. They're trying to maintain the airways open, and hence the term pink puffers. And the opposite of that is blue bloaters, which denotes patients who have bronchitis, obese, cor pulmonale secondary to chronic disease, and they look blue because of the cyanosis caused by hypoxemia. Eventually, this is going to give you a pretty horrific looking CT scan like this, and see how there are air spaces within the lungs throughout, as I'm marking there. The larger ones over here, as we've talked about, are called bullae, hence the term bullous emphysema. So that concludes today's talk. I hope you found value in this video. Please subscribe to the channel and hit the like button, and leave any comments below. I'll do my best to get back to you. I shall see you in the next video. Bye bye.